Hello? Mario, are you able to hear me?
See your hands on the table.
Okay, Mario.
Can you explain the case?
Yeah, one of my. Ready, sir. Case is ready. Can you show the PowerPoint?
Your voice now.
Can you hear me still?
Okay.
Yep. PowerPoint ready?
Yes, we can hear you.
Good morning, everyone. To take you through the next case. Our next case is a 10-year-old girl child who presented to us with bilateral lower limb claudication since the past 1 year. On physical examination, she had a Turner syndrome phenotype, short stature, height of 114 centimeters, pulse was 88 per minute, femoral pulses were not palpable, upper limb blood pressure was 140 by 80 millimeters of mercury. Aortic ejection click was present, but there was no murmur. Chest X-ray showed a dilated ascending aorta, a coarctation segment with a post-stenotic dilatation of the descending aorta, and rib notching was seen. ECG showed left ventricular hypertrophy. Apical 4-chamber view showing a left ventricular hypertrophy with a mild LA dilatation. Aortic arch showing a coarctation segment with a isthmus measuring 13 millimeters and a narrowest segment measuring 4 millimeters, and the dilated descending aorta segment measuring 21 millimeters. A peak gradient of 56 and a mean of 25 across the coarctation segment. So final diagnosis is Turner syndrome, severe coarctation of aorta beyond the left subclavian artery with concentric LVH. Plan is coarctation stenting. Thank you.
So can you go to the first slide? First slide. Yeah. So Mario, you can show the angiography live. See what
okay, we see the angio now, yes.
So with the right femoral artery access, the coarctation gradient was 55 millimeters of mercury. The ascending aortic pressure was 155, and the descending aortic pressure was 100 systolic, giving 55 systolic gradient. And then second picture. So what we did was we did a rotational angiography. You freeze it at LAO 40. Yeah. So we recognize that LAO around 40. Go to 40, 45. So we realize that this LAO 45 delineates the coarctation reasonably well. We done a measurement. Show the photos.
Yes, we saw the pressure below the cord, of course.
Yeah. So then we did a roadmap. So these are the measurements. We had a distal transverse arch of around 12 to 13, and the coarctation was around 4. And the distal measurement was around 19. So what we had was, right now I will show you live. We have two wires, one across the subclavian artery with a Judkins left through that, and we have a partially exposed stent. I'm going to give you some angiography. Contrast. So this is.
You can see the 3D reconstruction and iPilot overlay of the pictures.
Yeah. So right now in. So
so you have a single cover stand mounted on two balloons, correct?
Exactly. So I'm just bringing it below the level of coarctation. Hold it both. So right now, I'm getting it.
Can you, before going on, can you tell us what is the stent, the length, and the two balloons, the size of the two balloons mounted on?
The balloon is a bib balloon. It's 12 millimeter diameter and 4 centimeter long. The CP stent, covered CP stent, is 28 millimeter.
38 millimeters.
28 millimeter.
So you have one balloon. The balloon is on the wire in the right side, yes?
Yeah, exactly. So right now I am just opening out partially.
Yep.
And I'm making one check angiogram. We can see the coarctation part below. So I'm slightly pulling it out, exposing
the stent is more or less in the middle of the coarctation site. Yes?
Yeah. Can you inflate? Yeah, just to take the hand up, hands up, hands up. Yeah, quickly inflate. Inflate, deflate, deflate, fully deflate. So show this fluorostor.
Yeah, probably the patient moved away, so probably there is no a perfect overlay of the previously.
Yeah. Right now show the fluorostor. We will show you the inflation now. The right coronary artery catheter there is just guiding, telling us the location of the subclavian.
Yeah.
And the stent, the way it is deploying, it looks like probably we are 50% above and 50% below. See, the waist is at the middle of the CP stent. Right now, I will give a better inflation now. Go up to around, what is the burst pressure of, go up to 8. Go up to 8. Yeah, 8. 4, 6. Rotate. 8. Tell at 8. Stop at 8. 4, 6, 7. Enough, deflate. There is a small amount of recoil, fluorostor. The blood pressure
Looks like there is a bit of recoil on the stent.
Yeah,
yes.
yeah. So right now I will take out the balloon and see how is the hemodynamics. You hold the RCA catheter. Dr. Mario, we are having one small technical difficulty here. There is, since we are having, I'm removing the balloon. Since we are having one catheter and one wire across, the hemostatic valve of the Cook sheath is leaking a little bit. So I am taking out the balloon.
Yes.
So that I have only one catheter across.
Yeah. So you have a catheter crossing the stent going to the left subclavian.
Exactly.
And the wire in the ascending aorta right subclavian.
Yeah. So right now I am getting the.
So the pressure we are looking at the screen are from the side.
The side arm of the sheath.
Of the long sheath, correct?
Yeah, side arm of the long sheath.
Pressure curve seems much better as compared to the previous recordings, correct?
Yeah. So right now, what I will do is get a bleed.
Yes.
I'm going to look at an angiography through the side arm of the sheath. I'll just get
So what are you going to do now?
I'm going to get the side arm of the sheath advanced a little bit through the coarctation and make an angiography. I'll see whether I can get it coaxial and go across. We saw that the coarctation the post-coarctation aorta was a very roomy chamber, and so now I need to get myself inside the sheath has to go across. Can you give a pigtail across here?
Yeah, the patient is moving a bit too much, isn't it?
Yeah, the patient is on anesthesia. However, the effect of the sedation is slightly waning off. We are having a descending aortic pressure of around 130 millimeters right now. I'll get a pigtail across. So my pigtail has gone.
So you advance the pigtail over the wire in the ascending aorta.
Over the ascending aorta, yeah. So right now
Here
I'm going to have two pressures. One is below and one is above.
Yes.
Not seeing too much of difference between the two. I'll get both the catheters calibrated.
Can you enlarge the pressure lines for a minute?
Yeah, both the pressure lines.
You can see red and yellow lines.
Yeah, both are matching. The yellow one is the ascending aorta. The red one is the femoral sheath.
Yeah. So this seems completely the same. So no gradient any longer.
Yeah. So now I'm going to give an angiography. Yeah. Ready for an angiography? We have to see how much of flow is there across that subclavian artery.
Yes.
Ready for the angiography?
So the yeah. Yeah, it seems to me that the coarctation side is completely resolved. There is a bit of overlapping or jailing the proximal part of the stent to the left subclavian, but just in case you have a wire there, and
I have a wire.
You could flare the proximal part of the stent if you need it. Is that the intention?
Yeah.
Is that your intention, or you're happy with that?
I think I'll do that. I'll push in maybe a 8 millimeter balloon across the proximal ostium of the subclavian artery. What do you say, Dr. Mario? What should I do?
Well, at this stage, probably the stent is a bit too proximal. Would that be better to have a stent a bit lower down? However, we are still the room to flare the proximal part of the stent. What I would do now, I would put two balloons and inflate simultaneously in the aortic arch and left subclavian.
Yeah, I'll do that.
Warkan, what do you think?
Yeah, I think if we can flare that proximal part to be better. And well, just recently, Hiro in Japan, he has the same problem with this. So I asked him to use a Coda balloon, also usable Coda, just to flare the.
I want a stiff wire on this.
Yeah.
So yeah, but if we can do, we should.
Stiff wire. Yeah, I'll do that, Varakan. Now I'm listening to you. So get me a 12 Admiral Extreme and 6 Mustang. 6 Mustang on the subclavian and 12 admiral extreme on the.
Okay. Shiva, Ahmed has a question or comment. Ahmed?
One comment about the transverse arch. Transverse arch seems to be hypoplastic. So in this situation, I would like to use open cells or hybrid cell stent for both covering transverse arch and also coagulation. And then it is not problem, but we can cannulate the left subclavian artery, and then crash is possible with DMAT also.
Well, that's a possibility. However, in spite of the hypoplasia of the transverse arch, you have no gradient at all between the ascending aorta and descending aorta, so the hemodynamica is very stable. And the other point is that if you inflate or expand open cell or bare metal stent, well, you are taking more risk of dissection or something.
At the beginning, maybe suboptimal balloon usage, and then redilation is possible. Another issue that the proximal pulse of the pigtail when during the pressure recording was near the transverse arch.
No,
so
no. I will.
Yeah, but now we have the pigtail in the ascending aorta.
Yeah,
so the pressure is in the ascending aorta, right?
Yeah, it's deep inside. It's deep inside the ascending aorta.
Yeah. So actually, there is no gradient. Nick has another question.
No, just a little comment. I mean, even though there is no gradient, the long-term outcome of these patients is hypertension. And these patients with this arch will stay hypertensive throughout all their life until you relieve the gradient, the hypoplastic arch in total, because this arch is much too small for a patient of that size. So yes, we have relieved the coarctation. Technically, it's a wonderful job. We all agree. But I think the long-term outcome will be a hypertensive patient.
So what will you do?
But don't, Dr. Nick.
Or wait a second. Or you then have to completely stent the arch to a size which is appropriate for this lady's height and weight, which will round about 18 or 20 millimeters.
No, Dr. Nick, it's a...
Did you get the comment, Shiva?
No, it's a 10-and-a-half-year-old girl. I think she has got another 6 to 8 years to grow. I think that we need not be pessimistic about the transverse arch.
Yeah, these arches don't grow. They don't grow. That's an illusion. They don't
in the long term, the surgeons don't do a better job in adults with coarctation either. It's not risk-free procedure.
No,
majority of congenital surgeons shy away from transverse arch hypoplasia coarctations. They do not want them because the risks of paraplegia, ischemia, cord, all of those are not minute. They're actually significant.
I fully agree.
90% of surgeons, if you do a poll, they'll say do intervention.
No.
So you have to accept, even if you achieve a perfect result, hypertension is a chronic problem, whether it's hypoplasia or just resetting of receptors. So this patient, you've got a good result with stenting. Arch is hypoplastic, treat hypertension.
Well, the other option is to go for surgery, but not to the arch, but to an additional bypass, ascending, descending, and then you have a double orifice.
Oh, yeah. A very easy operation, that is. Yeah, brilliant.
No, that is an easy operation.
No, it's not.
It is.
If it was, the surgeons would be happy to do it all the time in this anatomy. They're not happy to do it all the time.
Yeah.
Oliver, it's got one of the best surgical teams in UK. Give us your surgical opinion, Oliver.
Yeah, I'm not a surgeon, but I think technically it's a very beautiful result. I share some of Nick's concern about the hypoplasia of the arch. And if this kid would have been 6 years of age or so, I probably would have asked the surgeons to patch the arch, but not to convert. The long-term results of convert or jump graft are horrible.
Now we mix something. The thing is, if it's a small child, whether it's 4 or 6 or 2, we all agree an arch repair with some form of homografting is the optimal solution. In the older ones, and even the adults, because of all what Jacques has said, the paraplegia and everything, this is not a good idea. But in those patients, the adult EMA or Gooch surgeons, if they have hypertensive patients, they do these ascending to descending order.
Well, in the meantime, you are advancing two balloons in the ascending transverse arch and the left subclavian, correct?
Yeah, we have two balloons. There is a smaller 6 millimeter balloon across the subclavian artery, and a 12 millimeter balloon across the distal transverse arch. So,
one more comment to Nick is this patient will need re-intervention anyway. She's going to grow another 6 years. I think the result at present is good. 50% of all coarctation patients will remain hypertensive, irrespective of everything. And I think one can always tackle the transverse arch if it should become a problem in future at a later stage.
Yeah, I fully agree. Now, having a stent pretty large there, you're seeing now flaring the distal portion of the stent. You're going to have a very nice access to the transverse arch if needed in the future. Yeah.
So right now what we have done is we have flared out the proximal lane as suggested by Dr. Mario. So right now I will repeat another picture.
You can also flare the distal part of the stent.
No,
despite the fact that distal aorta is very large, probably it will not be possible to get a perfect approach. Oops.
But
be careful about not to.
Dr. Mario, I don't like that distal flaring at all, and especially in a Turner syndrome, where if I create a descending thoracic dissection,
Absolutely.
So I don't like the distal flaring.
We don't have to forget that this patient has a Turner syndrome that theoretically has a higher risk of dissection or rupture as compared to, let's say, normal patients. Yeah.
So I will be repeating another arch angiogram.
We have another question from Mohammed. Go ahead.
Just to continue with Nick's comment, I had two patients, one was 16 years old and one was 17 years old. Exactly the photocopies of this patient. Transverse arch was small and hypoplastic. We stented, and there was severe hypertension in both. One patient went to Harley Street where they repaired the arch, the transverse arch, and they leave the stent as it was. The stent was in a good position, and the hypertension resolved. And the second patient was exactly the similar sort of pathology, which has a junk route from ascending to descending aorta. So I think this is a problem, the transverse arch, and it will be in the future as well.
So right now we again don't have much of gradient between the two. Hold the picture. So I'm taking out the other balloon and then I will make an angiography. Yeah, we are ready for the angiography. There was no gradient as of now.
Waiting for the angio.
Yeah, around 30 ml at 20 at 15. Fine, that's fine. Ready for the injection?
Oh, that's very good. The flow in the left subclavian is perfect. The stenotic point is completely solved. I think it's a very wonderful result. Well, there are concerns about the possible problem in the future for the transverse arch hypoplasia. However, I must say the immediate result is just wonderful. Congratulations, Siva.
Yeah, AP view.
Okay.
One more. 15 at 15.
So you're going to do a 3D rotational angiogram now after stent implantation, or what?
No, I am just repeating an descending thoracic aortic injection for any lower dissection at the lower part of the aorta.
Okay, so congratulations. Thank you very much.
Yeah, sure.
Bye. So we